Dr. Odai Dweekat from ChristianaCare to give us a talk on how AI and data science are being implemented at ChristianaCare. But before I introduce him, let me mention some housekeeping issues. We continue providing CME credits for our tech talks and our ID series presentations. We will distribute the information via email to those who registered for today's event. If you did not register prior to today's talk, you can still obtain CME code information from Deborah Rees, and she will post her email address in the chat box. We have some upcoming events. On December 16th, which is a Tuesday, we have an ID series, and that will be Dr. Kelly Kovatis from the NICU at ChristianaCare who will talk to us about working smarter with PNURIC. So you really don't want to miss this. Dr. Kelly Kovatis is a physician in the NICU here. And on February 6th, we have another tech talk. So next year, it's unbelievable that we are talking about next year. It will be on Thursday, and Alex Mapp and Kim Williams will talk to us about survey designs and steps to building a survey. So again, I'm absolutely delighted to introduce Dr. Odai Dweekat here. Dr. Dweekat is a senior data scientist in the Department of Community Health here at ChristianaCare, and he leads here advanced analytics and machine deep learning initiatives for program evaluation. He received a Master of Science in Operations Management from the College of Engineering and Physical Sciences at University of Birmingham in the UK, and a PhD in Industrial and System Engineering from Binghamton University, which is a state university of New York. And where he also received the Excellence in Industrial and System Engineering Research Award. Prior to being hired at ChristianaCare, he was a graduate research associate founded under the Binghamton University Watson Institute for Systems Excellence, and he was working here at ChristianaCare as a research associate, where he developed machine learning and operations research models to improve healthcare operations, such as forecasting models to address post-COVID staffing shortages, or models to predict hospital-acquired pressure injury. And I think he's going to talk to us about these models. He has already a long list of publications published in top-tier journals and presented at major scientific conferences, and he received several awards. The last one as a runner-up for the Society of Healthcare 2025 Vinod Sane competition for his project, Optimizing Nurse Staffing, a case study in forecasting models to address the February 2025 post-COVID-19 shortage and improve recruitment. So again, I'm really delighted and honored that Dr. Dweekat is giving us a talk today, and thank you so much.
Thank you so much, Dr. Claudine, for this kind introduction. Thank you, and thanks for having me here. Can you see my screen?
Yes, and I just wanted to add that Dr. Dweekat will take all questions at the end. And if you have questions, well, as he's doing his presentation, please put them in the chat. But he will address all questions at the end.
Yeah, sounds perfect. Thanks, Dr. Claudine, again for the introduction. And today I'm super excited to share how AI and data science work is being implemented here in ChristianaCare. So here, before I will start, I have no financial or conflicts of interest to disclose for this presentation. And before I should start, these projects are the results of teamwork. So I wanted to thank our clinical leaders, data scientists here, nurses, physicians, data analysis, and students, everyone who participate in this work, because this is not an individual work. There is a lot of work behind that. So each name here represents people who contributed their time, expertise, and passion for improving care. And for today's presentation, I will start with a very short introduction to AI in healthcare. Then I will deep dive into predictive models, case studies, starting with HAPI, then AKI, cancer readmission, and then go to operational models. For example, delivery to postpartum problem and the patient's feedback, patient comments, and then go to time series. And at the end, I will wrap up with lessons learned and portfolio impact summary. So at the beginning, in my opinion, like nothing can beat human intelligence. That's my opinion. And meanwhile, AI doesn't replace caregiver. When I mean caregivers, mean doctors, physicians, and those are in place. It helps them care of patients more effectively. And that's what we will see in this presentation. Because every case here represents a patient that we help, a process that we improve, a nurse we employed, and make it more efficient. Before going to our topic, I like this simple analogy, how AI works. I will not go with the technical because this may need another seminar, and I'm happy to do that again. But I will give, I would say, a big picture how AI works generally. And think about AI is a student studying like thousands of past exams, and it learns from pattern. And if we compare the human intelligence, like think about that you will study biology 101. You could go and study one past exam and you may get 25% results. If you studied more and studied two past exams, you may get 30%. If you keep studying, you may get like 100, you may get 95 or excellence. It's the same thing with AI. It's about mimic human intelligence. So AI in general is mathematics, statistics, and computational power. That's why NVIDIA will be dominant in the next few years. So here, the mimic process is based on something called artificial neural networks, but that's a different topic. But in AI, when we build a model, it's the same thing. It learns from the pattern. So if we build a model using 100 photo to predict lung cancer, to tell us based on those photos if cancer will appear or not, we will get nothing. If we increase the number of photos to thousands, we may get a decent result. But if we keep training the model to 1 million photos, we may get 99% accuracy. So in medicine or in healthcare, AI does the same thing. It studies pattern in millions patient records. So it helps identify risk earlier and more precisely. That's exactly how the mimic works in simple terms. So let's move now from concepts to practice, which is the topic of our seminar here. So the next few slides, I will focus here on some predictive analytics, like in real clinical problem. I will start with HAPI. So HAPI starts for hospital acquired pressure injury, and I think most of us knows that. Let me remove this very quickly. So it's not a good picture, but HAPI can happen everywhere. It can happen like in any part of the body, and it has like 5 stages. And FYI, it is one of the most common health conditions here in the US. And for those who doesn't know HAPI, it's bed sores, but it occurs while the patient cared in our hospital or any system. So think about a patient came without those wounds. After being admitted, those wounds appeared. That's why we call it hospital acquired. And I will keep saying HAPI during this case study. And of course, HAPI is the second most common diagnostic in the health billing records here in the US. It's not only like a headache, or it's not only in caused pain or longer length of stay, but we can see from those statistics how much does it cost. Like any wound in stage 3 or 4 cost between 75,000 to 150,000. Annual cost exceeded 28 billions a year. And see, the average male practice is 250,000. And those are not updated numbers. This is the most recent one that where I found. But it also affects the patient safety, I would say, across the system. And HAPI increases length of stay. As a result, it requires additional resources, and it can reduce the trust of any health system. So it's like a chain. It affects families, it affects patients, it needs more resources, and it has a lot of difficult managing the patient care. But the good news is we have Braden. And Braden scale in nursing here, like it's a systematic scale, it's a structured scale. It consists of 6 modifiable risk factors, as we can see. Each risk factor has a score of 4. So except friction, a scale of 3. So the total summation is 23. So nurses have this tool. They go to each patient, have the score every day. If the total score per patient is less than or equal 18, then they will label that patient at high risk of having HAPI. Other than that, they said no HAPI. So that's how clinically how nurses deal with HAPI. The good news about Braden, as we can see here, it can catch like HAPI very well. This is a real example at our hospital. Braden can catch 95% of HAPI cases if we have 10 HAPI cases. However, Braden is saying in order to capture those 95, which are 9.5 if you count them here, you have to provide prevention actions for 79. So if you count all of these, you need to provide prevention actions for 79, which is a lot. That's why we call it like high detection prevalence. In other words, the percent predicted as high risk is very high, which is cost in terms of numbers. And those here in black that were not identified calls false positive, which are, I would say, that leads for unnecessarily intervention because nurses needs to provide anyone that catches for not HAPI as extra work. That's the main disadvantage of Braden scale. Another disadvantage for Braden is it has lack of vital risk factors. In other words, we investigated based on the literature and based on the feedback and corroboration from the clinician that those risk factors are relevant to HAPI, but Braden doesn't use them. So, for example, medical diagnostic, uh, assessment, labs, medication. So those are not included on HAPI model, on the Braden model. So this project started with one simple question. Like, how can we help nurses focus on patients most at risk without overwhelming them? In other words, how we can reduce the false positive without replacing Braden. As we can see here with Braden, it can suspect most of them as HAPI risk, as at risk. So the purpose or the objective of this project was to merge or to integrate machine learning with Braden in one model, using the strength of clinical 6 modifiable factor with many non-modifiable factor in one model to reduce the false alarm and increase the sensitivity. So that was the objective. I will go to the methodology very quickly. It's a lot. For journal papers were published from that project. So I will go very quickly here, but I'm happy to answer any question or please feel free to send me on my email. We use support vector machine, the Braden scale itself, genetic algorithm. It was a hyperparameter optimization in the top of machine learning. It was cost sensitive learning. We did that because the HAPI rate was very low. In machine learning, this is called highly unbalanced problem. It's one of the most complicated problems in machine learning. So we use sophisticated method on that. And the target was to predict patients with high risk of developing HAPI. We used 98 risk factors. Using our data, we have our inclusion criteria, exclusion criteria. in order to simulate what's going on. So everything here based on the clinical feedback, what to exclude, what to include in order to have our final target, which were around 100,000 patients. So I will skip those details, how the model it works from technical point of view, and I will jump to the results. So here the results, this photo, it's not even the result, it just shows the top 20 risk factors identified by the model, and most of them have HAPI, which means we didn't replace HAPI. HAPI was the dominant, but we used the clinical model and we built on it. And we operationalized the model through a live dashboard and automated. It's automated every day at 6:30. And this report and dashboard is sent by CSIM to walk nurses leader before the rounding. This is an example. Then I will jump to the results. So now we trained our smart guy, our smart model, based on 101 records, relevant records. So now we have a smart guy saved at CSIM, and he can distinguish if HAPI will happen or not. So today is November 6th. We pushed all the data, the current data for each patient, the risk factor that are demographic, Braden scale, diagnostic, everything to the system every morning. And this smart guy is telling us what are the classification, like who will have HAPI and who will not. And based on that, we are updating our dashboard for the walk nurses every single morning at 6:30, and they can filter out like 3D, for example, unit. They can see, I hided the name for privacy, but they will see the first name, last name, PIN number, the units, and the high risk of being at HAPI. This is the most important slide here for the HAPI. This will show you the compared performance between if we implement Braden alone without using AI and the power of AI. In terms of sensitivity here, we increase the sensitivity from 6.1, if you count those, to 7.7. At the same time, we reduce the false positive from 42, if you count those in black here, to 17, using the power of AI. So we cut false alarm by more than half. At the same time, the percent predicted, those inside this circle, we reduced them from 42 to 17, which means we flagged far fewer patients as high risk. So rather than telling nurses deal with 42 cases, they are dealing with 17 cases. So that allows nurses to focus only on time on truly high cases patients, rather than reacting on every single alert without replacing Braden. So we are building on Braden. That's the output. And very quickly, this project, the clinical impact, it gives early intervention enabled with better allocation for our resources without increasing the burden on them. And shout outs for walk nurses. We worked very hard with them to reprocess the current process, and they are providing tons of intervention actions. And we redesigned the workflow improvement here, and of course this saves 1.25, because see here, rather than dealing with everything, we just reduce it. So that's annually. That's about AKI. For the time's sake, I will go very quickly, not like in this depth. You know the idea now, and I will try to be very quick with other projects. It's more or less the same methodology, but this is the main idea of the first section. The second section has different methodology, but for this second project, this is in progress. It's post-op AKI, acute kidney injury. And in simple term, it's a sudden decline in kidney function occurring within the 7 days of the surgery. So this is a timeline for the surgery. I will try to simplify that in simple terms, and maybe Dr. Claudine here, the expert on that, she can explain it much better than me. But think about I'm a patient. I will have a heart surgery today. So if I came to the hospital to treat my heart, during the surgery, if something happened, if the blood pressure was not enough, so the blood will not go directly to the kidney. So during that surgery, there will be some injuries in the kidney. So I came to treat my heart, but I will ended up with something with my kidney within the 7 days. So that's called post-operative AKI. And this has a lot of effect. It increased the length of stay because I came to treat my heart, then I will ended up with something different. It will increase the mortality, the length of stay and cost. And based on Delaware's benchmark, each case cost more than $25,000 as direct cost, not including the indirect or overhead cost. And at ChristianaCare, the AKI percentage is 6.25, which is a bit high. Not high, it's not like the the HAPI. HAPI was 0.57. So, and we have mass production here. So the goal of this project is to predict AKI 1 to 7 days even before the surgery. So the surgery, let's say today, 7 days ago, we should tell surgeons and the clinical team what's going on, like to predict 1 week before and 1 day before, in order to give them time and enable early intervention to improve the patient management. That was the theme of this project. So we designed the model based on our data. We used around 28,000 related cases. And this table was a collaboration between us, data scientists and surgeons and clinicians. We did literature review and they modified it, and we worked with IT in order to have those relevant factors which simulate the most risk factor for the AKI. And we used interpretable model to tell them why this classification was positive. It tells the answer, like creatinine was high. The patient has like came from high risk zip code, or it has like this surgery or that surgery. So this model increased the transparency build because we are answering for every single patient why the model classify it as positive or negative. I will jump to the results. The results are great. The sensitivity is 75%, which means out of every 100 patients, we can capture 75 AKI correctly, 1 to 7 days before the surgery, and those are the top features. And it has very good potential effects because at ChristianaCare we have tons of surgeries and the AKI percentage is high, and each case costs a lot. For more validation, we did tons of validations. We did internal validation, pre, post, in order to make sure that the model is consistent and the model is not memorizing. In machine learning, we call it overfitting. So we did all of these models, all of these tests, then to confirm that the model is robust and telling exactly what's going on. And we have the intervention right away. And we will start implementing this project with, I think, the surgical department soon. Very quickly with another project with oncology readmission. It's the cancer readmission. That project was before I started. It predicts the cancer readmission, who will be readmitted in 30 days. So we use the top features. It reduced the readmission by 10%. It saves a lot. My part exactly here was something called model drift. So over time in machine learning, the sensitivity started degrading because of accurate treatment pattern or some other factors. So we did something called model drift. We retrained the model using extra data, using extra features. And at that time, we discovered that language was a new factor, like patient language. Because think about when a patient doesn't speak English, then it has most probability to come back to the hospital. The last project here, very quickly again with the predictive models, is hip fracture length of stay. So this project predicts whether if a patient would stay more than 5 days or less than 5 days from day one. By knowing that early, we could coordinate rehabilitation, physical therapy, and discharge planning proactively. And the sensitivity was 62%. Now, these projects demonstrate clinical AI. Now I will move to another operational projects using more or less the same methodology, but for the operations. This project is with postpartum with the Women's and Children Hospital. And before going to the hospital, let's think together about this flow. This flow represents the flow of patients for women's for labor and delivery, starting with admission, then labor and delivery, then we have a baby here. Then after we having a baby, the patient should be moved to postpartum after having the birth. So there will be time here between moving the labor and delivery to postpartum. Then when we have the postpartum, the length of stay should be 1 to 2 days, then discharge. The problem here that we face that we have a bottleneck here in between. So the time from after delivery till sending to the postpartum, the average was 5.7 hours with median 4.02 hours. And in a process, this is called a bottleneck because it will have delay and we have empty rooms. Everything, like, it's not a matter of resources, it's not a matter of escort, it's not a matter of nurses. That's why nurses rose that question, why? So the purpose was to uncover what's really driving these delays to identify actionable factors. That was the trigger. And before we start, this is just a distribution of our cohort. The national benchmark should be here. But see, most of our patient has like 60% are between 3 to 5 hours. And we can have 7% more than 10 hours. But the goal was to shift 2 hours earlier here. That project was very big. We started with all cases with C-section and vaginal from 2020 to 2024. Then we know what we need to focus. So we decreased the period from March 2023 to November 2024, and only I will present the vaginal deliveries cases only. So we ended up with having 6,800 cases. We collected 366 potential factors here for every single patient in order to measure this time. So our target is this time now. We used feature engineering, feature selection, and association rule mining. And before going to the results, those FYI, this table summarizes the 366 potential factor, like why the delay happened. And potential demographics. Here we have clinical. And I remember when we asked for the data, Susan here, she is in the call. She told us, okay, there is the escort problem. That's why, Susan, maybe now I need to answer the question. That's why after March 2023, escort was there. But before that, you are right. So that's why escort was not included here. So we have tons of comorbidity factors here. So long story short, we identified those factors and we filtered out those factors to come up with 28 significant factors. And we find like hypertension was one of the top factor, preeclampsia, gestational diabetes, and so on and so forth. But this is not enough. It is good. But what if, who is contributing more? Still, like, what's the value of hypertension? Or like here, like triage time. But what's the triage time? Is it less than 2 hours, more than 5 hours? Because each factor here has sub-factors. So we did a lot of analysis and think about if a woman came with hypertension, is it the same time with hypertension with preeclampsia? I'm saying here about the combination. What if a woman came with hypertension, preeclampsia, and induction, and obesity? So we did something called association rule mining to have those rules. But before going that, we did a lot of analysis here. For example, this is 014.14. This is severe preeclampsia. This still nurses. If a woman came with preeclampsia, 95 probability of having high time based on our data. And here again, we tested over 1 million variables combination from those sub-factors in order to reveal the hidden factors grouping and telling them what's going on. So those insights tell them a clear picture. For example, here, if a woman came with BMI more than 35, severe preeclampsia and chronic hypertension, the time will be, or it was, 787% higher than our median. So over 1 million combination, now we have around 100 combinations. So they know now if a woman came with those conditions, start working on that. And here just telling them on visualization, for example, if the same example, BMI more than 35 with gestational diabetes, based on our data, that takes 25 hours. Only the time between delivery to postpartum, which is a lot. So I will jump to the summary. Like ultimately, we transfer intuition into evidence. Like at the beginning, we know nothing, like why this delay happened. But now it's not no longer intuition. We uncover the real time, we uncover those factors and the combinations, and we started working on that process that process. Now I will jump to the third part of analyzing patient feedback. We use NLP here to uncover insights from hospital patient feedback. That was a very big project because it has 6 phases. I will ask you here, before I ask you this question, I'm not challenging you, but this is called word cloud. As you can see here, for those who are not familiar with word cloud, so these word clouds were built based on our patient comments in ChristianaCare using our 3 campuses. So the larger, as we can see, the word, the more often appears on patient feedback, more frequent. Like nurse was the most frequent, then doctors, then care, and so on and so forth. But the question is, what do you think patients are saying here? What stories are they telling? Can we change the process based on this? We need to change some or to enhance the process. That was the trigger for one of the biggest project with the patient experience subcommittee led by Mark. So when Mark and Howard came and discussed the problem statement, they have tons of questions because they are responsible for sleeping and the cleanliness, which are the 2 key drivers for patient satisfaction. And the problem statement we have tons of thousands of comments. Scores means nothing. We have scores, but score doesn't answer those questions. Can score answer what exactly the patients are saying about sleeping or cleanliness? What themes matter most? How big each issue and why the patient dissatisfied? Which campus or units are struggling the most? What should be focused? So this is literally a black box. So think about, you are a leader. You need to change the sleeping and the cleanliness. You need something. You need to open this black box and transfer those tons of comments to improvement actions. That was the trigger. I will go very quickly to this flow chart. It needs more than 3 hours to go to the details, but very quickly, we collected the comments. We did the comments classification, which is sentiment analysis using Vader. And we focused only on negative comments. We did topic modeling for sleeping and cleanliness. We did another topic modeling for sleeping to give us the subtopic, which is the reason for each one. using rule-based matching. Then we did unit and campus analysis, then the root cause. Don't worry, I will explain it in very simple terms in the next few slides. But before going there, this project was evolved into different 5 projects, different 5 phases. So we started with the sleeping and the cleanliness. Then we dig deeper. Okay, dig deeper to linen sheets and blanket. Noise from nurse. I will explain this in this presentation, and so on and so forth. Before going to the result, this is for you how an example how unstructured data was transferred to structured data. This is the 3 real comments, by the way, like no sleep roommate, blah, 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 blah. So this means nothing, but what we did, we changed these comments. We added one sentiment, which is negative, which was negative, positive, or neutral. Then we added the category, which is here, sleeping, and the subcategory. We map that with campus and unit. So once we have this measurable insights or this, we can do anything. We can measure what's going on. And I will go to the results directly for the noise from roommate. Out of around 17,000 comments, and using this methodology, we were able to filter out only 120 relevant negative comments, only about noise from roommate. And we were able to tell what were the key themes here. This is good, but still gives nothing, no directions. That's why we need to do more deep analysis. But before going to that, here I need just to explain one example, what each theme means, the description and real examples. Those are our examples from our patient. And those descriptions and themes came from the literature review from John Hopkins scale or benchmark. They are using those scale at their patient experience. And here, listen, you just read, like patients are complaining about housekeeping staff. They are saying they are noisy. And they are saying about, see here, listen, a nurse plan her wedding and another shower, blah, 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 blah. So now we will try to tell the leaders what our patients are complaining about. Same for electrical device. Same for screaming and yeah, this is a major problem in Wilmington. We will go to that. And the roommate activities and all of these patients. And we have others. Anything other than that, we have it like other. Like patients are complaining about the security team. And going to the results, we compare the distribution of those negative comments with every comments. From that, we can see like Newark had the highest proportion negative comments, which means that Newark is struggling. Start with Newark. Because Newark 75% of those noise from roommate came from Newark versus 57% of total comment came from Newark. So you have a benchmark to compare now. And this is the overall units where they are focused, like for the 3 campus. But this means nothing because we need to split this into different campuses. So if we need to look at Newark, most of the complaints came from our ED, 7E, 2E, and so on and so forth. And our patients are complaining about those the top. So now the management or the leaders of Newark can start at least with 3 units and focus on 3 factors. Same for Wilmington. Wilmington, they are not, our patients are not complaining about our staff. They are complaining about other patients. They are saying they are screaming and yelling. So staff intervention is number 3 here. So they are different. ED is number 1 and then 4W. Same for CCEL and same for Middletown. We considered Middletown as a separate entity because to have one table like this, because the management will not go for this. This is good for data scientists, but the management needs this table. Newark is struggling. Why? Because of this. Where to focus? Focus on those top 7 units. Don't work with like 37 units in Newark. In terms of noise, Wilmington the same. Those are your top 3. So now we open the black box for noise and noise from roommate. So now we can send this to leaders, and this is a summary with, so remember, it was nothing here. So the comment was a black box in terms of noise from. After the insight, we have process changes. So we open that black box. We identify a specific units level driver. And now the committee has no longer questions because it's no longer a black box. So we evolved this project into another five domains. I will not present another 5 projects, just one slide for projects. We did the same for sleeping and cleanliness. We did also pre-processing the unit level, the campus level for every one of this. And here the linen sheets and blankets. And based on that, we changed the process last year. We changed the frequency because our patients were complaining that you are changing the frequency, you are changing the linen every 2 to 3 days. So we changed the process. So now we could open the black box and change. Same for comfort of bed. We replicated the same methodology to know what our patients saying about comfort of bed. And we started with comfort of bed and like linen because those were the top, as you can see, the top reasons for sleeping. So we use Pareto rules, like start with your big problems. And we did the same for HAPI as well. Like what our patients are saying, we found like 52 comments are saying about HAPI. Like your matrices are very strong, very hard. And they are struggling about the pressure point. So now we know which units are saying about. And send that to Susan Mashalli. That was like everyone was a step. That's how data science and machine learning were used here. Same for temperature control. Our patients are using, are complaining about the temperature. So now I will jump to the last topic here very quickly because of the time series forecasting. So now we will move from perception to prediction. I will explain 3 cases here. I will start with the baby delivery volume. So this model is telling the leaders at Women and Children what is the forecasting for baby and deliveries in the next 2 months. So they can anticipate the seasonal pattern and allocate resources accordingly ahead of time. And the results are very good. The accuracy is between 96 to 100%. And after that, we expand that project to a daily forecast. So now we are sending each Wednesday the forecast for the next 7 days. So this is daily forecast, gives operational leaders 7 days outlook. The accuracy is not like the monthly, but still good, and it can be improved, by the way. The last project before going to the last section is optimizing nurse staffing. That project was used 2 to 3 years ago. Now it's no longer in use because it was designed for post-COVID when I was doing my PhD. So if you remember 3 years ago, there was fluctuation on patient census. Wave 1, wave 2, wave 3. It was a headache here, and it was high turnaround for nurses. And because of the fluctuation and uncertainty, that make like understaffing a lot or overstaffing and burnout. So the nurses, when they came to us, the leaders, they said, okay, we have a problem. We have a problem with our HR about the finance, about having the budget. Because our budget doesn't match with the finance budget. We need a tool based on science to tell us what is the projected budget based on this fluctuation. So that was the trigger at that time. So we did the classification here per medical group. We did forecasting for our patient census. HR was there. They give us a lot of assumptions about the PTO, attrition, nurse to patient ratio, and we converted that for full-time FTEs. And based on that, we were able to have the new higher budget for them. So the portfolio impact for those projects, you can look across this portfolio, you can see the collective impact from clinical prediction to operational efficiency to patient experience, and together this project shows how AI and data science is being used here. By the way, those are not the only projects. We have tons of other projects, especially with CSIM. They are working on data science. I worked on other projects, but I can't do everything on one project. I just selected the big projects here. So that's the impact of the projects. And the most important slide for me is the lessons learned. So for data scientists or anyone, collaboration builds trust. So include clinicians in every single step from the early beginning. Collaboration is the key here. We included our nurses, surgeons from every single point, from data collection, from literature review. Like we found this, what do you think? From data, missing data, like if the creatinine is low, what do you think? We can use our statistical method, like you use median, but listen from them. Sometimes they have different idea than what statistics recommended. And try with simplicity. Make it simple, stupid. Like don't go with complicated things, because if they don't understand what you are doing, then that model will not be adopted. And the value is defined by improvement, not by fancy platforms or expensive consultants. So in healthcare, this is my golden rule, process re-engineering matters. Without re-engineerings, this process will fail. Even if you bring the smartest AI model from OpenAI, apply it to your institution without process re-engineering, that would fail. That would definitely fail. And for data scientists, no algorithm fits all. You have to do a lot of experimentation to see what is the best. But don't take all of the results and overwhelm nurses. Just give them the final results. And real impact comes from people, process, and purpose. It is not only AI. So bringing AI or a system or smart system will not change everything without changing the process. And the process needs collaboration between purpose. And before doing that, start with the purpose. What's your purpose? So don't start with AI because everybody is using AI. Then it's gonna fail. If you don't have clear direction, what you wanted to achieve, then start with the people and change the process. And the last lessons learned is start small, do a pilot, then prove it, then scale it. So that's the lessons learned. And thank you so much for your time. And I'm happy to take any question, any feedback. And thank you for your listening.
Well, Odai, this was absolutely amazing. I mean, all of us learned a lot, I'm sure. And I think for each topic you could give a talk. So
yes,
we should have planned you for 12 topics, 12 talks. This was really amazing. Any questions for the audience, from the audience? We have a couple of comments in the chat, but not really questions.
And also maybe Dr. Claudine Robert can have some comments for AI because he is working on something on AI here about the privacy. And so please, Robert, feel free to comment here if you have any feedback. Because I know you are working on it.
Now, Dr. Dweekat, I think your presentation is amazing. You solving real world problems, and this is what is important. I think when we think of AI, we want to make sure that we are solving problems, and that's exactly what you're doing. So on our end, what we're doing is working with information security, we're working with IT, we're working with legal, and we're working with other stakeholders within the organization to make sure that we have the governance process, the AI governance process in place to support some of the work that you and the experts are doing to help our patients, to help our caregivers. We have the policy in place. It's already published in a policy manager, so you can take a look at that. We are in the process of creating our SOP to make it easier so that people understand whether the AI project is initiated internally or is a third-party product, so that people understand the intake process, the AI intake process. So we're drafting the SOP. That will go out very soon. The governance committee is already established. And then we have education coming up. We're working with Karen Gifford and John DiGiovanni and the rest of the team to make sure that we have AI education for everybody, so that everybody will get education on AI. And then, of course, we're working with Anahi and her team to make sure that the security controls are appropriate and for what we're trying to do here. We're looking at, the FDA requirement. We're looking at ONC. We're looking at Office for Civil Rights, and also making sure that, especially with EPIC coming on, there are a lot of requirements for health IT, and we want to make sure that regulations like, the HT1-1, HTI-1, and the FDA, software as medical device, all those requirements are met. So we'll continue to work with you and support the great work you're doing. So thank you so much.
Sure.
Thank you, Robert. It's very important information. Any other questions? So I have a couple of questions.
Please.
While people are thinking. I guess, which model was it? It's probably in the AKI model. You listed, the most important features that you had identified, I guess, through the SHAP analysis. But when you do your prediction, like, I guess every morning or whenever a patient comes for surgery, for cardiac surgery, do you include also other features or just the most important? And I think there were like 7 or 8 most important features.
Yeah, that's a great question, Dr. Claudine. Let me reshare my screen again. Yeah, so when we have, that's a great question. This is the AKI. The AKI, think about that, it was built on those 29 factors. So all of them were included, correct? When we are sending the prediction for surgeons, each patient is different from another patient. So we are telling them why this patient specifically is different. Why this patient is yes, why this patient is no. So it answered the question like the creatinine here was high. The CKD is 1. So here it's just interpretable tool for each individual patients by patients. And if the patient is classified with no AKI, then it tells why. Like the creatinine is low, not high, the patient doesn't have CKD, or the EGFK is, normal. So it's case by case. That will increase the trust and interpretability for each patient. But the feature importance is for all patients, That's the difference.
I see. I think it's the next, the next slide where you list the features that are the most important.
This one?
Yeah. That was for the
this is for HAPI, yeah.
HAPI. But so do you do the same thing here where you include all the features? All because here you have the top 20, but in your prediction model every morning, do you include all the features that you have identified, or
That's
just the top question. 20?
For AKI, we include them. For everything. This is just the top 20. Yeah.
Okay.
Yeah.
Robert,
so everything will be included, but yeah.
Okay. I understand. Thank you.
Robert, do you have a comment?
So I know this is not a federated system, but you're dealing with patient information. So how did you ensure differential, privacy here to ensure that I'm asking about differential privacy. You don't have
Yeah,
to go into it, but it is very important, especially when you're operating in this domain, given the sensitivity of the information that you deal with.
yeah, that's a great. I expected that question, to be honest, from you. Let me share something. Here. Where is it? So what we did, Robert, we identified the patient facility ID and the patient names for our model. So for the HAPI, for example, when we build this model, we bring 1,000th record without the name, without the patient ID. Just each patient has the risk factors. So in this case, as a
So
developer,
quick
yes,
question. This is not a federated type of data. So if it's not federated, do you still need differential privacy though? That's what I was trying to get to.
could you please explore it more here?
I mean, go ahead. Go ahead.
I mean,
Continue.
in machine learning, I would say we don't care about the patient's name or patient's privacy. You know what I mean? So when we train our model, we de-identified all of these personal information. So we trained the model based on the pattern, regardless who was the patients. When we deploy the model, every single morning, we push the patient's information. So in this case, personal patient information will not be in touch, like name, but we will use the age, gender, all of these, but we don't know who exactly was the patients. That's how we try to make sure that we don't touch the personal information.
Okay. So, but you don't have to inject noise into the model, right?
No.
You can do it without injecting noise specifically into it.
Exactly.
Okay. Thank you.
It is safe. Don't worry about that. It's like international, like global thing, like when a person deploy or even make the model, like train the model, I would say personal information will not be used, like name. Like you can't use name, but you may use age without knowing the name of that patient, or the ID, or where it was, or the address. Sometimes we use the zip code.
But
Thank you.
I mean, for the HEPI model, I mean, you have to provide the name of this patient to the nurses. So in the last step, you provide this information.
Yes. Yeah, what happens that in deployment, Dr. Claudine, let me go to that slide. That was the slide.
Right.
Like, think about now we have 10 patients. So what we did, we pull their data, feed them to the model. The model was trained, and then based on that, the nurses will know if that patient is high or low. But in this case, who is our audience? Only nurses. So they have
Right.
only access for the leaders. Sure. Nobody can know the name except the WOC nurses leader. A real example now, Erica, like the current WOC nurses leader, changed to another department. So yesterday they contacted me, I contacted IT. We need an access for the new leader. So now we gave her access. After a month, we will remove the access from the current leader. So nobody can see all of this information except the leaders who are making the rounding.
That's an amazing feast of technology here. You know, congratulations to you and to IT to be able to do this. That's really amazing. To be able to really, you know, identify the right patients and give the information to the nurses.
Donnie, a quick question in the chat
Please.
from one of our attendees before they sign off. The data you used, the 101,000 patients, was that all real data or did you utilize synthetic data at all?
Oh, that's a great question. This is our data. So what we did here, that's a great question. And in order to end up with, where is it? It's ChristianaCare data. We pull all the data from 2020 to Feb 2024. Then after filtering those criterias, we ended up with our real data. So we are not using synthetic data. This is a pure ChristianaCare data. That's why if we need to replicate this model to CHOP, for example, we should build it from the beginning because the target is different. The age group is different. You know what I mean?
Right.
That's a great question.
you. Thank you.
Sure.
All right. It's 101. Any other burning question to Dr. Dweekat?
Thank you, Dr. Claudine, for having me. Thanks again.
You know, I think what I would like to do is to have you to get a little more in depth, mostly on the notes, projects, so the patient comments.
Sure.
Because we need to. I'd like to have more information about this. This is absolutely, incredible work, and I'd like to know how really it works. But I didn't really understand.
Yeah, sure. I'm happy to do that, Dr. Claudine, in the future.
Okay, that sounds great. Well, thank you so much. I think we had a major, really large audience, and you have a lot of comments in the chat congratulating you. So thank you so much. It was a fabulous presentation, and
Thanks,
we'll have
Dr.
you
Claudine.
again.
Yeah, sure. Thank you. Thank you again, Dr. Claudine. Thanks everybody for your attendance.